My name's Professor Matt Murray. I work both at Addenbrooke Hospital as a paediatric oncologist, as a consultant, and also in the Department of Pathology here at the Centre of Cambridge, where we have a lab which myself, Professor Nick Coleman, and Dr. Cinzia Scarpini lead a program, and that's particularly working on children's cancers. The specific type of children's cancer that we are really interested in and have got a long track record of working with are patients with germ cell tumours. So germ cell tumours are tumours that arise from egg or sperm forming cells. So they can occur right the way through from babies through to late adulthood. So from 0 to 80 years of age. They can both male and female patients, and they can occur, as I've said, because they come from egg and sperm forming cells, can form in the ovaries or the testes, but they can also form in the midline of the body. So they can occur at the base of the spine, the back of the tummy or abdomen, the back of within the chest, and also within sites in the brain. So as a result of their rarity and their different ways of presenting, they are a difficult tumour to potentially diagnose and to manage. And we've really tried to focus on finding common changes that occur in the cells that are regardless of all this difference. And one of the things that we found as part of our research work is that there are short pieces of genetic code that occur in the tumours at very high levels and don't occur in any other cancer type or any other disease state. So these little pieces of genetic code are very, very specific for this type of tumour. And we've gone on to show that these levels of microRNAs, these short pieces of genetic code, are very high in the bloodstream and in the circulation at the time of patients' diagnoses. We try and link the research work that we do in the Department of Pathology to clinical benefit here in Cambridge for patients. So for an example, one of the tests that we're developing, which is using blood tests and spinal fluid tests to try and make non-invasive diagnosis of children's cancer, is one of the things we're pushing towards clinical practice. So this is a scan of a patient with a tumour very centrally located in their brain. And when we move through, we see that this patient has a tumour shown here by the bright white area, which is very centrally located in the brain and can be quite challenging for the neurosurgical team to go in and take a biopsy. And that can be associated with risks of the anaesthetic and needing to access that very central area of the brain next to important structures, for example, that are involved in eyesight and hormone production. And we can take a spinal fluid sample, which is easy to obtain, and we can test it. And that has a really high sensitivity and specificity for picking up those tumours, meaning we can make a really accurate diagnosis and sometimes obviate the need for the neurosurgeon to go in and take a biopsy.
My main work here is processing clinical samples of pediatric patients that come from the hospital. These samples are mainly serum and cerebral spinal fluid that we call CSF. And what we normally do is test these samples for the presence of tumor markers, which are specific for germ cell tumours.
The current markers that we have in the clinic for diagnosing these tumours are only positive overall in about 50 or 60% of cases. So there's a lot of patients in whom the diagnostic workup, all the tests that we do to try and identify which tumour type patients have, aren't very sensitive in picking up those patients. And this microRNA test is sensitive and specific in terms of picking up disease and making sure this is the type of cancer we're dealing with in over 90% of cases. And at the moment, it's still a research test, but we're working very hard with the lab team to try and produce all the evidence that we require to allow this to become a test that's a routine NHS test that any doctor within the UK can order as part of their patient's routine testing.
I'm heavily involved in this project that we have at the moment, which is to move our diagnostic test from the university where we are currently running to the GLH in Addenbrooke Hospital, so that it will become available for all our patients to use directly through the NHS. My work is very varied. Sometimes I will do works with cells, so little things that we grow in petri dishes. Sometimes I will do work on a bench, doing something that we call PCR, which is a way of quantifying little bits of DNA or RNA in solution.
My research has been focusing on Wilms tumour. So I've been investigating the use of circulating microRNAs to act as a non-invasive diagnostic tool. So Wilms tumour, just a little bit about that. It's a paediatric kidney cancer, and currently it's diagnosed using imaging tests like X-rays and CT scans. But it's hard sometimes to differentiate between tumour types with just the imaging. So the idea is that with liquid biopsies, it's a non-invasive alternative to that to try and help with the diagnosis. So I've been looking at trying to identify a panel of microRNAs to use to help make sure that the diagnosis is correct. One of the challenges with the work that I've been doing with Wilms is that compared to the germ cell tumour work, where there's one specific microRNA that's upregulated, Wilms is a lot more heterogeneous, which means that patients, their microRNA levels are a lot different between patients, which means that I've had to try and find a panel of microRNAs instead of just one.
This is just one example of the way that the research we're doing in the lab, just down the road in the centre of town, can be helping patients here in Cambridge, in the whole of the east of England, but also nationally and internationally, to help move forward towards a minimally invasive or non-invasive diagnosis of children's tumours, including brain tumours. Slightly longer term than that is our work trying to find kind of treatments for patients with germ cell tumours. The current conventional chemotherapy treatment for patients with germ cell tumours is highly effective and most patients are cured. But there are a lot of side effects of current chemotherapy schedules with regards to impact on kidneys, hearing, cardiovascular systems, and sort of effects on the heart, which can occur within a sort of few decades of treatment. So we really are trying to maintain those very high survival rates for patients, but actually cure patients better with less side effects. And one of the same changes that we see in the bloodstream as we choose as marker, those high levels of the microRNAs, these short pieces of genetic code, actually help to drive these tumours to continue through the cell cycle and divide and make more cells. And we've spent a long time in the lab reducing levels of those very high levels of microRNAs in the cancer cells and showing that reduces cell growth. Conversely, levels of microRNAs that are abnormally low levels in the cells, we've actually replenished those levels by putting them back into cells and showing that also slows cell growth down. And those low levels of microRNAs and high levels of microRNAs act in a concerted fashion on the cell cycle to allow those cells to keep dividing. And we've shown that either bringing high levels down or making low levels higher, to back to more towards what we find normal levels in other cells, actually reduces cells cycling through the cell cycle. So we think that's a potential treatment that we want to explore in more details. And that's work we've done currently in what we call cell lines, which is the work we do in petri dishes. And we're extending that work to look at effects in combination with other drugs and whether we can reduce the dose of conventional chemotherapy agents but still successfully treat patients.